Okay. Okay, so our topic today is shock and stabilization of acutely ill patient. As you all know, shock is a huge topic and very difficult for me or for anybody to present it in 2 or 3 hours. But what we will do, inshallah, is to talk about the principle of shock. What's the definition of shock, and how the body react at the cellular level in a case of shock. What are the symptoms and signs of shock? So how we can recognize this patient in a state of shock. And after that, of course, we need to know the causes and the stages of shock in order to apply the treatment according to the cause of the shock. So the first thing is what's shock? As we all know, our body requires oxygen, and we are alive because of the oxygen. So the cells utilizing the oxygen, and the oxygen delivered from the heart to the cells by the blood. So we need to have a good amount of blood volume, and also the flow of the blood from the heart to the cells. What causes the flow coming from the heart to the cells or the tissues is because of the blood pressure. So we should have a good blood pressure. So in state of shock, what will happen? There will be inadequate tissue perfusion, either to the low blood volume or decreased blood pressure, or the heart is actually not pumping enough blood to oxygenate the cells and the tissues. So decreased delivery of oxygen, and as you all know, if there is decreased oxygen to the cells, especially to the vital organs, which are the brain and the heart and the kidneys, the cells will go into anaerobic metabolism. So what it will produce lactic acid, and this results in lactic acidosis and metabolic acidosis. And the cells now starting to be dysfunction. And if we don't recognize the patient in a state of shock and will not act as early as possible, what will happen? The cell will die, tissue will die, and of course the patient will die. So we'll just talk about what will happen at the cellular level. So one moment, if I get the pointer. So if you just imagine with me, this is a normal cells, yeah, normal happy cells, and this is the blood vessels, okay? So there is good blood flow, good blood pressure, and the white particles is the oxygen, and this one is the CO2. So there is enough oxygen going to the cells, and there is aerobic metabolism. The cells, they're happy and they're producing ATP, and functioning well. So in a state of shock, what will happen? There will be reduced oxygen to the cells, okay? And at this time, what will happen to the cells? The cell membrane lost its integrity, okay? And loss of electrical gradient, the action potential. So there will be leak of potassium, goes outside of the cells. And this is what we can see in a patient with in a shock state, in the metabolic acidosis. They will have hyperkalemia because of the leak of the potassium outside of the cells, and also mitochondrial damage. And now there is less oxygen, so there will be anaerobic metabolism, and this will result in production of lactic acid and lactic acidosis, and will be severe, metabolic acidosis with high anion gap. So this is what will happen actually at the cellular level. In addition, if there is a septic shock, what will happen? There will be, secretion of the endotoxins, cytokines, nitric oxide, and this what will do? They will cause dilatation of the blood vessels. So the blood will be stagnant in the blood vessels. So there will be like, what we call it, relative hypovolemia. Okay, and also there will be increased capillary permeability, and the blood will be leaking outside of its vascular compartment. For that, there will be, the blood might comes out from the blood vessels, and this leads to activation of the coagulation process, platelet aggregation, and formation of small blood clots, and consumption of the clotting factor, and this is what we call it DIC, disseminated intravascular coagulation. Also, in the anaphylactic shock, it will do the same thing. What will happen is, increase of the histamine, and this will cause, vasodilatation, increased capillary permeability, and it will cause, hypovolemia. So we'll go to the first question, Dr. Mohamed.
تمام. المفروض هيطلع السؤال على سكرين لكل الحضور. طبعا choose one correct question، فتقدر تختار الإجابة. تبدو تختاروا الإجابات. ماذا بينا الكل يشارك. زي ما قلت لكم الإجابات مش هتطلع بالاسم، هتطلع عندنا احنا في الريكورد فقط، في الريكورد الخاص فينا. فماذا بينا نضمنوا لا ما نبوش إجابات في الشات، نبوا الإجابة مباشرة هتطلع عندك في السكرين، سواء من الموبايل أو من الكمبيوتر هتطلع السؤال هيطلع على السكرين. فحاولوا لأن حيكون عنده وقت محدد وحيتحول السؤال.
طبعا السي او اللي هي الكاردياك اوتبوت، this is the heart rate and this is the systemic vascular resistance. Okay.
اوكي تقريبا تمام. اوكي حنديروا شير للريزلتس. الريزلتس ما يقارب 47% منكم جاوبوا النقطة رقم بي اللي هي كاردياك اوتبوت تساوي الهارت ريت ضرب السيستميك فاسكولار ريزيستنس.
اوكي
تمام دكتور. اوكي
So I can get to, I'm trying to get to the next slide.
لأن في بعض منكم مرات حنديروا جاست تيست للكويشنز باش نكونوا فاميليار مع الأسئلة بالطريقة. حيطلع سؤال بسيط جدا للحضور، فيفضل أن الأغلبية تجاوب. أقل شيء نضمن الريكوردينج للناس اللي الحضور. سؤال بسيط جدا. وفعلا السبت غير موجود كالعادة. فعلا أغلبكم جاوبوا يوم الأحد، واليوم هو يوم سبت، لكن السبت غير موجود. فهذا تمام. مسد هو الأمانة، ما فيش مشكلة. هي الفكرة أنك أنت to get familiar مع الأسئلة والإجابة ونضمن حضور الناس. شكرا. تفضل دكتور، كان تستمر.
I'm trying to get to the next slide, but I don't know.
عادي.
Stuck. لحظة بس. I don't know why it's not.
ستوب شيرنج للسكرين وبعدين عاود شير من جديد. تمام.
مش عارف, I cannot go to this next slide. I don't know why. Okay. So what are this is the cardiac output, and the cardiac output is the amount of the blood ejected by heart per minute. Okay, and it's equal heart rate multiplied by stroke volume. Okay, so what's the stroke volume? Stroke volume is the amount of the blood ejected by the heart per beat. So this is per beat and this is per minute. So if we multiply them together, the heart rate and the stroke volume, which is per beat, equal the cardiac output. So the cardiac output is the amount of the blood ejected per minute. Okay. So the stroke volume depends upon what? Depends upon three things: the preload, contractility, and the afterload. The preload is basically the venous return, the amount of the blood, coming from the tissue to the heart. Okay, so it is what we call it the end diastolic volume, and this is the stretching of the heart. So as the amount of the venous blood increase, the stroke volume will increase, and this will increase also the cardiac output. Contractility of the heart, if the contraction of the heart is good, so its stroke volume is also good, it's high, and this also increase the cardiac output. What's the afterload? Afterload is the pressure or the resistance that the heart to overcome to eject the blood. So actually it is the squeezing of the heart to overcome the resistance to open the aortic valve. Okay. So this is quite important. Why? Because we can see after that, how the body reacts when there is a state of shock. As I mentioned, it's very important to have a good blood pressure in order for the blood to flow and to get from the heart to the tissue to supply oxygen to the tissue. And the blood pressure equal the cardiac output multiplied by systemic vascular resistance. So what we mean by systemic vascular resistance is the vasoconstriction. So when there is a vasoconstriction, the systemic vascular resistance will go up, and this will increase the blood pressure. Okay. The MAB, which is the mean arterial pressure, which is actually the blood pressure, okay? So equal the cardiac output multiplied by systemic vascular resistance. So the cardiac output is the heart rate multiplied by stroke volume and multiplied by systemic vascular resistance. The mean arterial pressure, it's actually, it's a good indicator for the blood flow rather than the systemic blood pressure. So we measure the mean arterial pressure. And what's the mean arterial pressure equal? Equal the 2/3 of the diastolic blood pressure plus 1/3 of systolic blood pressure. So usually when we say mean, اللي هو average, usually you divided them, you add 2 and divided them by 2. But in the blood pressure is different, okay? So you have to take 2/3 of the diastolic plus 1/3 of systolic. Why is that? Because the blood pressure is not, I'll try to just do the diagram to understand what's the, this is the diagram. Okay, so this is the diastolic blood pressure. Let's say it is 70. Okay, oops, sorry. And systolic, let's say 130. Okay, so if it is like this, you know, rectangular shape, so what's the average here between, you know, 70 and 130 is to add them together and divide it by 2, yeah, which is roughly around 100. Okay. So if you put that there, so roughly this one equal this space. But in blood pressure is completely different. It's not rectangular, okay? It is a graph, so it will be like that. Go like this and goes like this. Okay. So if you take the average, the mean arterial pressure, and you want to do it the same as 100, so what will happen? This space is larger than this. Okay. So that's why you need to take, you know, 2/3 of the diastolic plus 1/3 of systolic. So if you add 2/3 of the 70 plus 1/3 of 130, it will be less than 100, around 90. Okay, so it will be around 90. Oops. So 90. So this space is equal this space. So that's why, you know, the mean arterial pressure, the 2/3 of the diastolic plus 1/3 of systolic. And it's very important, you know, to keep the mean arterial pressure equal or more than 65 in order to have a good flow of blood and good oxygenation to the tissue. So what will happen when a patient is in a state of shock? There will be, you know, activation of the sympathetic system, and the activation is because of the stimulation. When there decrease blood pressure, there is a parareceptors in the carotid sinus and in the aortic arch, and this will activate the vasomotor center. And this activation of the sympathetic activity and increase of adrenaline and noradrenaline. So what it will do, it will increase the heart rate and it will increase the contractility of the heart. So when there is a state of shock, what will happen? The heart rate will go up, the contraction of the heart, you know, becomes more in order to, you know, to compensate and to elevate the blood pressure. The same thing when there is a sympathetic activity, what will happen? It will act on the alpha-1 receptor and causes vasoconstriction. So when there's a vasoconstriction, what will happen to the systemic vascular resistance? It will go up. When it will increase, this, you know, increase the cardiac output and it will increase the blood pressure. So this is the reaction when the patient is in a state of shock. The body tries to compensate by activation of the sympathetic system, increase the release of adrenaline and noradrenaline, and increase the heart rate, increase the contractility of the heart, and causes vasoconstriction. Also, there are other factors, like, you know, when decrease blood flow to the kidneys, what will happen? They will increase renin and angiotensin 1 and angiotensin 2, and this also, causes secretion of aldosterone, and aldosterone increase the absorption of the sodium and water. So they try to compensate by keeping, the blood volume by reabsorption of the sodium and water, and also causes vasoconstriction. The other factor is release of antidiuretic hormone from the atria and from the pituitary gland because of the decreased volume and also because of increased osmolality. And antidiuretic hormone, as you all know, increase the reabsorption of the water. So they try to keep, the water inside the blood vessels in order to increase the volume and increase the cardiac output. Another action, which is really less important, is what we call it a local autoregulation. So when there is decreased blood flow, especially to the vital organs like brain and the heart and the kidneys, when the decreased blood flow, what the vessels will do, it will vasoconstrict in order to increase the pressure. So these are the physiological changes, and the body try to compensate in a state of shock. But the main thing is the sympathetic activity, increase the heart rate and the contractility of the heart and the vasoconstriction. So what are the stages of shock? There are 3 stages. The first stage, we call it compensated or pre-shock. And what will happen, as we mentioned earlier on, there will be a compensation. So the body try to compensate, okay? Try to compensate by increasing the sympathetic activity, increase the heart rate, vasoconstriction, increase the secretion of renin and antidiuretic hormone, and they will, to try to keep the blood pressure as the same, right? So this is the pre-shock state, and we should recognize the patient in this stage, all right? So if the patient comes with tachycardia and cold, clammy skin, and the blood pressure is normal, we should think about this patient. He might go in a state of shock if we don't recognize it early, and if you not act as quickly as possible. So if we don't recognize it, or if the patient comes late, he will go into another stage, which is the decompensated shock. And this is the state of shock where the patient becomes hypotensive. And of course, when there's a hypotension, there will be hypoxic injury to the tissue. So if the compensation mechanism, which is what was in the stage 1, we don't recognize it and we don't treat it as well, the patient goes into state of shock. So what will happen in the cells if they become hypoxic? For example, in the brain, if the brain tissues, there is no enough oxygen supply to them, the patient becomes, drowsy, they become confused, and he might be in a stage of coma. For the heart cells, there will be an ischemia. The patient might complain, of chest pain. There might be ischemic changes in the ECG. Also, the patient might have, arrhythmias like atrial fibrillation, or he might go into ventricular tachycardia, etc. Oxygen supply to the kidneys, if it is less, what can cause, decreased urine output. And if you check the bloods, you'll find urea and creatinine to be high. For the lung, as we mentioned, there will be increased capillary permeability, there will be pulmonary edema, and the patient might end into adult respiratory distress syndrome. For the liver, also, there is hypoxic damage to the liver. The liver function test, they will be high, and the patient might end into hepatic failure. For the bowels, ileus, ischemia, bleeding, and as we mentioned, the patient might end into disseminated intravascular coagulation. So this is a very important stage. We need to recognize and treat the patient. and the patient might, able to treat him if he's in this stage. If not, he will go into stage 3, which is irreversible refractory shock. And this is persistent hypoperfusion and hypoxia, and it will result into multi-organ failure, and the patient will die. In actual fact, clinically, we cannot recognize if the patient is in stage 2 or stage 3. Okay, so in stage 3, we'll try, to resuscitate the patient, giving him fluid, giving him antibiotic. We start vasopressor. But if he's in stage 3, the damage already happened. Okay, so there will be no recovery. For example, as you can see, if some of the patients, like in ICU, they are intubated, they are on vasopressor, and they are not recovering, despite the blood pressure is fine, but the tissue already damaged. There is multi-organ failure, and the patient will stay in ICU for days, weeks, and he had a brain death. At the end, we'll say, oh, the patient is already died. Why? Because he is in irreversible refractory shock. So how we recognize that the patient in a state of shock? When the patient arrives, what are the symptoms and the signs that tells me that this patient in a state of shock? So he will be, initially, he will be tachycardic, as we mentioned. The heart rate will be up because of the increased sympathetic activity, secretion of adrenaline and noradrenaline. So the heart rate will be, patient will be tachycardic. There will be, patient might be, confused, anxious, decreased level of consciousness because less supply of oxygen to the brain. And again, the respiratory rate will be high. Why? Because he's in metabolic acidosis, so they try to increase the rate of breathing to wash out the carbon dioxide. The skin, of course, as we mentioned, because of the vasoconstriction, so the blood, they try to deliver it away from the skin to the vital organs, so the skin would be called diaphoretic skin. There will be, of course, decreased urine output and hypotension. So these are the signs that the patient, when we check their vitals, we'll find all those signs. So now we'll talk about what are the types of shock. So there is hypovolemic shock, when there is the volume of blood actually is reduced, and this could be hemorrhagic and non-hemorrhagic. Cardiogenic shock. There will be obstructive shock like tension pneumothorax, cardiac tamponade, and massive pulmonary embolism. So these are the obstructive shock, and I put them under cardiogenic shock because at the end it will cause cardiogenic shock. That's why I put them under the title of cardiogenic shock. The other type of shock is the distributive shock. So here is the hypovolemic shock. The volume is decreased, but here the volume is fine, but the distribution of the blood or the intravascular blood volume is mal-distributed. Most of the volume is outside of the vascular compartment. So there's a problem with the distribution. And the main cause of this is septic shock, anaphylactic shock, and a neurogenic shock. So we'll take them one by one. Hypovolemic shock, as we said, it could be because of bleeding. It could be because of non-bleeding, like non-hemorrhagic shock. Hemorrhagic shock, in the cases of trauma, could be external bleed, could be internal bleed, like rupture of aortic aneurysm, injury to the internal organs, ectopic pregnancies. Non-hemorrhagic, like massive gastroenteritis or major burns. So this all cause hypovolemic shock. So what you can do about it? What you do if the patient comes, if a patient had a trauma and he's in a shock state, we should think about, hypovolemic shock until proved otherwise. So what we'll do about it, the first thing we should do is to stop the bleeding. Because it's very important, you will, first of all, you will try to resuscitate the patient. But if the patient is keep on bleeding, there is no use of resuscitating them. So you have to think, about stop the bleeding. How do you stop the bleeding? It could be external, okay? You can see the bleeding. So you have to do direct pressure, or you can use tourniquet. And if there is deformities in the, in the limbs, what you can do splint to reduce the, try to reduce the pain and try to stop the bleeding inside the limb itself. The other thing is, if you think there is a pelvic fracture like open pelvis, you can reduce the pelvic volume by putting a pelvic binder. And the important thing is, if there is internal bleed, you have to take the patient to theater in order to stop the bleeding. Okay, so what we call it, on the floor plus 4 more. So on the floor, bleeding is external. You can see it outside the body, or four compartments, which is the chest, abdomen, and pelvis, or long bones. So on the floor plus 4 more. So we can take this MCQ, Dr. Mohamed.
اوكي، حاولوا تقروا السؤال على السكرين قبل. اوكي تمام. اوكي شباب، اي حد قبل لا نوقف السؤال؟ تقريبا تمام. I already shared the results. الماجوريتي من المشاركين مسجلين او جاوبوا على البيدسايد التراساوند، اللي هي الانسر helpful making diagnosis which is contribute on timely management. تمام دكتور.
مش عارف انا لما تدير في السؤال ما عادش نقدر نخش على النكست سلايد. I cannot go to the next.
حاول فعلا حاول تغير البوينتر. او ستوب شيرنج ودير شير. اوكي تمام. ايوه
Okay.
تمام.
So the next thing, if the patient is, in a state of hypovolemic shock, so how do I locate the bleeding? So of course, in any trauma patient, A, B, C, D, okay, airway, breathing, circulation, disability, and exposure. It's very important in all patients of trauma. Of course, you have to examine your patient initially, taking history and examination. And another diagnostic tools that will help, to locate the bleeding. You can do chest X-ray to see if the patient had, hemothorax, X-ray of the pelvis to see if there is a fractured pelvis. And very important to do the fast scan, the bedside ultrasound, especially if the patient, became hypotensive or deteriorated during the resuscitation. It's very quick, it's very sensitive, and you can see here there's, free fluid in the right hypochondrial space between the kidneys and the liver. And this is, as I said, is quite sensitive to this patient. If he had internal bleed, you start resuscitating him, and this patient definitely he needs to go to theater to to locate the bleeding and to stop the bleeding. The fast scan, if it is negative initially, it doesn't mean that the patient he didn't have an internal bleed. So you have to do a serial test, because sometimes the first test might be negative, but when you do the second one, especially if the patient deteriorate, you might find free fluid in the abdomen. And it also needs an experienced physician to do that, because it's different from one person to another. So what I can do about it, of course, you need to restore the volume. You get 2 IV large bore cannula. You take blood, of course, for a CBC cross match is quite important, and you start giving a fluid to the patient. Vascular access, warmed fluid is very important, and you need to give backed RBCs, fresh frozen plasma, and platelets. And if the patient is initially systolic blood pressure is less than 90, or there is a poor response to the fluid, or you suspect ongoing major bleed, you have to activate what we call it a major hemorrhage protocol or massive transfusion protocol, in order to not to give a lot of fluid, normal saline to the patient. So you need to give him packed RBCs, fresh frozen plasma, and platelets, what we call it 1-1-1. So 1 unit of packed RBCs, 1 unit of fresh frozen plasma, and 1 unit of platelets. And why is this? Is to prevent what we call it dilutional coagulopathy. Okay. Vasopressor, of course, you need to give it if the patient not responding to the fluid. But as I said, it's very important to stop the bleeding. Another thing is you can give tranexamic acid. Tranexamic acid, you have to give it within 3 hours from injury. I think it's 1 gram over 10 minutes, and then you can give infusion after that. It's very important to keep the systolic blood pressure around 90, not more than 90. Why? What we call this? We call it this controlled hypotension, because what will happen? There will be a blood clot inside the blood vessels. Okay, because of the bleeding, the platelet aggregate and formation. And this will cause more bleeding, also because of the dilutional coagulopathy. Very important, the response. Why? Because if you are giving fluid and the patient not responding, it means that you are not giving enough fluid. If there is a hypovolemia and your patient giving him fluid and he's not responding, you have to think about another thing that this patient might have, like tension pneumothorax or cardiac tamponade or aortic disruption. You have to think about all this. Prevent hypothermia, of course, it's quite important. That's why you need to give warm fluid, especially in elderly and in children. So how do you evaluate the response? You are giving fluid and you need to monitor your patient. How you monitor your patient? You monitor your patient clinically. If the patient improve, his level of consciousness, he was drowsy and confused, and now he's fully conscious. Urine output becomes more. Skin becomes warm and capillary refill. Respiratory improvement, improve the rate and the depth of breathing. And of course, when you check the vital signs, the blood pressure now becomes more, patient becomes less tachycardic, becomes less tachypneic. So this is, factors or signs that there is an improvement in organ, or a good response from your resuscitation. So what's the patient response? The patient response related to the volume and whether there is continuous bleeding or not. There are rapid responder, there is transient responder who respond initially and then deteriorate, and there is non-responder. And this is dependent upon the, what we call it, classes of bleeding. So in class 1, there will be around 750 mils of blood loss, which is total about 15% of the blood volume loss. And this patient's like, the one who is a person who is giving blood transfusion, 1 unit or 2 units of blood. So there is no continuous bleeding. Patient is responding. His vitals really more or less to the normal, and blood pressure is normal, and you're just giving him fluid in the form of colloids or crystalloids, and the patient is absolutely fine. So this is class 1 hemorrhage. Class 2, if the patient lost more than 750 up to 1.5 liter, so it's around 15 to 30%. Still, those patients are responding. He's mildly anxious, respiratory rate now slightly increased, patient slightly tachycardic, urine output might minimally reduced. Now the blood pressure is normal. Why? Because of the compensation mechanism. Because if you check the pulse pressure is the systolic minus diastolic blood pressure. So what will happen because of the vasoconstriction, there will be an increase in the diastolic blood pressure. Okay, the systolic blood pressure will be low and the diastolic blood pressure will be high. So that's why if you measure the pulse pressure, it will be low. But the normal, the systolic blood pressure will be normal. And those patients, they respond to crystalloid, and you might think, giving them blood. In class 3, these patients, they are either transient or non-responder. And this is when they lose more than 1.5 liter, up to 2 liter, which is 30 to 40% of their blood volume. Here we will see really the state or signs of shock. So the patient will be confused, he will be tachypneic, tachycardic, urine output reduced, And here, when you see, the blood pressure coming down, as well as the pulse pressure also be reduced because of the compensation mechanism has been exhausted. And here you need to think about, giving blood, activation of the major hemorrhage protocol. So you can give blood type specific, which can be ready, within 15 or 20 minutes, or you can give O negative if the patient really is not responding to the fluid and he's deteriorated. And of course, you need to think about taking the patient to theater if there is an internal bleeding. Class 4, who's non-responder, there is 2 liters of blood lost, and those, the marked, shock signs to be there. Patient more tachypneic, more tachycardic, urine output negligible, marked reduced in the blood pressure and marked reduced in the pulse pressure. And definitely those patients, you need to give them blood, and you need to, thinking, taking them to theater. Now we'll go to cardiogenic shock. So cardiogenic shock, actually, it is the illness is in the heart. So the heart cannot pump blood, okay? And this can be caused by acute coronary syndrome, like myocardial infarction or unstable angina. So the heart is not pumping enough blood to the tissue. It can be caused by cardiomyopathy, different kinds of arrhythmias, like fast AF or ventricular tachycardia, bradycardia. They all can cause cardiogenic shock. Other causes, congenital anomalies in the heart or valvular disease. So the disease itself, it's a primary illness in the heart itself. So the heart cannot pump blood, so there will be reduced cardiac output, reduced blood pressure, and reduced tissue perfusion. So what are the signs of cardiogenic shock? What are the symptoms and signs? So the signs of hypoperfusion, the patient comes, with chest pain, comes with shortness of breath. When you listen to his chest, there will be crepitation, basal crepitation, peripheral lower limb edema. There might be distended neck veins, and when you do an ECG, there will be, either signs of ischemic changes or any kind of arrhythmias. And of course, history, you need to take a good history. Those patients, usually they have risk factors like, hypertension, diabetes, smokers. So those, you need to think about checking those symptoms and signs. And how you diagnose cardiogenic shock. You diagnose them, of course, by taking history and looking at the symptoms and signs. And also there's diagnostic tools that you can do. Of course, ECG is very important. You can check their troponin, arterial blood gases, lactate, chest X-ray when you can see cardiomegaly, echocardiogram to check the contractility of the heart, and you can measure the cardiac output. You can check their central venous pressure, which is measuring the right side of the heart, or pulmonary capillary wedge pressure, which is the measuring the left side of the heart, and also you can check their cardiac output. So how you treat patient with cardiogenic shock? Of course, you need to look at the cause, and you treat the cause of the shock. So oxygen therapy is very important. So you need to keep the oxygen saturation up, either by giving them oxygen by mask, or you can do, non-invasive ventilation in the form of CPAP. As I said, identify and treat the cause. So if the patient in arrhythmias, and he's unstable, so you can do cardioversion. Cardioversion here is synchronized cardioversion, not like a patient in state of cardiac arrest when you do asynchronized cardioversion. So any patient with in a state of arrhythmias like fast AF or VTAC, and the patient is unstable as we are in a shock state, you need to do cardioversion. Pacing, of course, if the patient is bradycardic, you need to think about BCI for the patient who's having an MI, valvular surgery, and coronary artery bypass surgery. And don't forget, if the patient has ischemic heart disease, an MI, you need to give them, of course, aspirin, morphine, and oxygen, nitroglycerin, etc. Cardiovascular support is very important because here this patient, they will not tolerate too much fluid. So you can give fluid, a little amount of the fluid just to check, but don't give them too much fluid because those patients, they are not hypovolemic. The problem it is in the heart. The heart is not pumping blood to the tissue, so you can support them by cardiovascular support in the form of vasopressor or ionotropic agents to increase the contractility of the heart. So you can give them, adrenaline or dobutamine. Dobutamine is a good drug which act on the beta-1 receptors. So we can take this another question, Dr. Mohammed.
Okay, so تمام. What is the earliest sign of cardiac tamponade? اوكي تمام تمام. الغالبية منهم طبعا جاوبوا انه الهايبوتنشن is the earliest, yes, is the earliest sign of cardiac tamponade. تمام.
نعطوهم الإجابة ولا؟
عادي لا عادي ما عادي فيش مشكلة.
Well, the earliest sign is actually tachycardia. All state of shock, the earliest sign is tachycardia. So the correct answer is tachycardia. Yes. Going to the next slide. No problem. Going to the next slide.
Do right click. Do right click.
Always when there's an MCQ, I find it difficulty to get to the.
عاود sharing جديدة.
Still the same problem.
stop sharing وحاول تمشي للسلايد اللي بعدها ودير sharing من جديد.
No. Mm-hmm.
تمام.
Okay. Thank you.
Okay.
So obstructive shock, the first one is cardiac tamponade. So what's the cardiac tamponade? Cardiac tamponade is accumulation of blood or another fluid in the pericardial space. So it's not necessarily just the blood, because it could be, cardiac tamponade can result because of the infection, pericarditis, neoplasm, rheumatoid arthritis. This all, if there is huge and acute accumulation, they all can cause cardiac tamponade. So the fluid will accumulate in the pericardial space and causing pressure to the heart. So the heart cannot pump, and they will be reducing the cardiac output. So this is why I put it also under the cardiogenic shock. So what are the signs? What we call it PICS triad. PICS triad is distended neck veins, muffled heart sound, and hypotension. But in actual fact that when the patient presented with hypovolemia because of trauma, distended neck vein, it will not be there because of the hypovolemia. Patient is bleeding, you cannot detect that there is distended neck veins. Also, it is difficult to hear the heart sound, especially in the noisy emergency department or trauma unit. You cannot detect the heart sounds. So the only signs that you might face is hypotension. So if the patient presented with penetrating injury into the chest, especially to the left side of the heart, and the patient is pulses electrical activity, or you should do a fast scan, so you can detect it very quickly, and you detect that there is cardiac tamponade. And what you can do about it, you can do pericardiocentesis, in which you can drain the blood from the pericardial sac. So pericardiocentesis, it is diagnostic as well as treatment. And of course, this patient, you need to go to theater to evacuate the accumulation of the fluid in the pericardial space. Okay. So we'll go to another question, Dr. Mohammed.
تمام. خلي يقروا السيناريو. 40 years old van driver has been brought to the emergency department with severe shortness of breath. He was involved in RTA. There's a bruising over his sternum and penetrating injury caused by a part of broken steering wheel. His neck veins are distended. هذه واحدة. With systolic blood pressure of 80. هذه اثنين. And pulse rate is 140 per minute. Trachea is displaced from the midline. معناها shifted. But breath sounds are difficult to hear. His oxygen saturation is 89%. What is the most likely diagnosis? السؤال متاع اتي الاسرع. والسؤال بتاع امتحانات. اوكي تمام تمام، تقريبا 80% منهم شاركوا، 82. I will stop. اوكي هنا الريزلتس. طبعا اغلبيتهم جاوبوا على انه هو تنشن نيموثوراكس، 49% منهم. اوكي
Okay.
تمام
Yeah.
دكتور.
So the correct answer is tension pneumothorax. Why it is not cardiac tamponade? I mean, the key point here is the trachea displaced from the midline, and also very difficult to hear the sounds. So in cardiac tamponade, it will not cause shifting of the trachea to the opposite side. Massive hemothorax, it can cause, yes, it can cause it. But here, the important thing that you need to think about is the tension pneumothorax. Because if you miss this and you don't treat it immediately, the patient will die. So the first thing you have to think about it is the tension pneumothorax. So we'll talk about the tension pneumothorax. So what will happen in the tension pneumothorax? Actually, the patient presented with severe dyspnea and pleuritic chest pain. And this, what will happen, the air get trapped in the pleural space between the parietal pleura and visceral pleura. So because of the disruption of the pleura or tracheobronchial tree. So the patient, when he breathes in, the air accumulated in the pleural space, and it is one-way valve. So the get accumulating inside and will not go outside. And as the patient becomes more distressed, becomes more anxious, he will try to breathe in, and the condition getting worse as the air get trapped in the pleural space. And what will happen? It will collapse the lung, and then will cause compression of the mediastinum to the opposite side, including the trachea. And the blood vessels, the veins, which is the superior vena cava and inferior vena cava, get also compressed, get kinked, and this will also reduce the venous return to the heart. So the heart is compressed, cannot pump blood outside. So there will be decreased cardiac output, decreased venous return to the heart, and also this is all cause decreased cardiac output, decreased blood pressure. The other thing is, patient who's liable to get tension pneumothorax, the patient who is in ICU under ventilation, especially those patients who is having COPD, they can easily goes into tension pneumothorax. So what are the signs? The signs, there will be distended neck veins, absent breath sounds, or hyperresonant on percussion when you do it on the side of the pneumothorax, and deviation of the mediastinum and trachea to the opposite side. Again, distended neck veins might not be there if the patient has hypovolemic shock as well. So the blood will be less, and you cannot detect that there is distension of the neck veins. So what you will do if you think there is a tension pneumothorax, don't take the patient to the X-ray, doing an X-ray, because if you do that, patient ultimately will die in the radiology department. What you can do bedside ultrasound. It's very quick, and you can detect it immediately. But again, if you don't have an ultrasound and you think the patient had tension pneumothorax, you should do immediate decompression by needle decompression. And you insert this needle, large bore needle, in the 5th or the 6th intercostal space, just anterior to the mid-axillary line. Before, they used to put it in the 2nd intercostal space, but the new guidelines now, you need to put it in the 5th or the 6th, anterior to the mid-axillary line. In children, yes, you can still do it in the 2nd intercostal space, but in adult, you have to put it laterally where you put the chest tube. So you keep the needle inside, and you prepare, the patient for putting the chest tube. Okay, another question, Dr. Mohammed.
اوكي تمام، خلينا نقرا السيناريو قبل وبعدين هنطلع السؤال. Otherwise healthy 53 years old male presents acute shortness of breath, pleuritic chest pain, his oxygen saturation على room air 85, and he is hemodynamically stable. The patient underwent an appendectomy أسبوعين فاتوا, and his post-operative course was complicated by abscess, which is required a week-long hospital stay. والسؤال: what is the most appropriate investigation for this patient? تقريبا تمام. Okay, I will stop and so I will share. معظمهم جاوبوا عنه هو CT pulmonary angiography. هذه كان.
Okay.
تمام.
Yeah, and this is the correct answer. Why? Because from the question here, this patient is a high risk of pulmonary embolism. He had a surgery, and he's been staying in the bed for a considerable length of time, and also his symptoms, shortness of breath, pleuritic chest pain, low oxygen saturation. So don't waste your time, doing the D-dimer, waiting for it. You have immediately, you can give him, anticoagulation in the form of enoxaparin, and immediately you need to do CT pulmonary angio. If it is a low risk patient, yes, you can do the D-dimer. But if it is a high risk patient, and clearly it's a high risk patient, straight away you should do CT pulmonary angiography. And the risk factor, as you know, it is what we call it Wills criteria, modified Wills criteria. You need to do, there are different, parameters, which is the heart rate more than 100, hemoptysis, if a patient had malignancy, signs of DVT or past medical history of DVT or pulmonary embolism, major surgery, or patient had a bed rest for more than 3 days, and if the BE is more likely diagnosis. Okay. go to the next one. Yeah. So we'll talk about massive pulmonary embolism. So massive here is very important, because if it is not massive, patient he will not be in a state of shock. So what we mean by massive pulmonary embolism, actually the pulmonary artery is completely obstructed. So there is no blood coming from the heart to the lung. Okay, that's why the patient he will be in a state of shock. We're not talking about segmental pulmonary embolism or minor pulmonary embolism in which patient can be discharged safely from the hospital. We are talking about massive pulmonary embolism that obstruct the pulmonary artery, and the patient will be in a state of shock. So there will be severe chest pain, shortness of breath, hemoptysis. Patient will be hypotensive. The diagnosis is to do CT pulmonary angiogram, and the treatment you have to give heparin and fraction heparin or tissue plasmin activator اللي هو alteplase in the form of 100 milligram over two hours, and then you can start infusion of the heparin. You start with 5,000 units, and then infusion after that in the form of 18 units per kilogram per hour. Of course, if the patient deteriorate and not responding, you might do intervention radiology and embolectomy. The D-dimer actually has high sensitivity but low specificity. So what does it mean? The high sensitivities are approaching nearly 100%. So any patient who has a positive D-dimer, most likely they will have a pulmonary embolism. But there are also false positive when you get the D-dimer is positive, but the patient he is not having pulmonary embolism in cases of pregnancy, infection, malignancy, and post-surgery or post-trauma. The problem with the D-dimer has low specificity. So if it is negative, the D-dimer is negative, it doesn't mean that those patients they don't have pulmonary embolism. So that's why you need to check, with Wells criteria or modified Wells criteria to check if the patient is a high risk or not. If it is a high risk, immediately you should go ahead and do CT pulmonary angiogram. Okay, another question, Dr. Mohammed.
اوكي تمام. سيناريو ثاني 50 سنة old patient who is known to have diabetes mellitus and hypertension. He came to the emergency department with history of cough, breathlessness, and high-grade fever for past 3 days. And he did chest X-ray in the private center where the doctor told him that he has pneumonia. The question: which one is not a criteria of SIRS or SIRS? تمام. Okay.
So seriously, a systemic inflammatory response syndrome.
تقريبا اوكي 80% شاركتوا، والآن هذه الريزلتس اللي هم اللي يعتبروا في ان الهاي بان and creatinine is not in the criteria of SIRS. اوكي. تمام دكتور.
Okay, this is the correct answer, the high urea and creatinine. It is not one of the parameters of the SIRS, systemic inflammatory response. So what's the SIRS? SIRS is the temperature if it is less than 36 or more than 38, heart rate is more than 90, respiratory rate more than 20, and white cell count if it is less than 4 or more than 12. So this is the initial response, of the body for the sepsis or septic shock. I go to the next slide. Mohamed, can you put the next slide?
I need control. Okay.
Okay. So we'll talk about distributive shock. So here the volume is normal, but there is a problem with the distribution. The blood is not in the vascular compartment because of the sepsis. As we mentioned earlier, there will be like vasodilatation, increased capillary permeability because of the sepsis. So septic shock is quite common, and the thing is it's having a high mortality. High mortality approaching, almost 40% of the patient with septic shock, they will die. Usually patient who's elderly, who's immunocompromised. Infection can be caused by bacteria, by viral infection, by fungal infection. Serious, as we mentioned, it's a high mortality rate. So what will happen initially? There will be vasodilatation. There will be increase in the cardiac output. The oxygen saturation in the venous, it will be high. So the arrow here is high. Yeah? Oxygen saturation in the venous blood will be high. Why? Because the cells, they're still utilizing oxygen. So there will be less oxygen in the venous system. Less oxygen in the venous system. So there will be there should be arrow, directed down. Less oxygen saturation in the venous system because the cells, they're still utilizing oxygen. There will be warm skin, increased respiratory rate, patient tachycardic. But if we leave this without treatment, patient, he will start having relative hypovolemic shock. There will be vasoconstriction, decreased cardiac output, skin becomes cold and clammy, and there will be an increase in the oxygen saturation in the venous blood. Why? Because now the cells, they cannot utilize oxygen. Oxygen will be more in the venous blood. There will be pulmonary edema, adult respiratory distress syndrome, multi-organ failure, and disseminated intravascular coagulation. So it's very important, because of the high mortality, to recognize the patient in a state of sepsis. So what do we mean by sepsis? Sepsis is the presence of known site of the infection plus serous. Okay, this is sepsis. So you know that there is, for example, lung infection, and there is, for example, increase in the respiratory rate or increase in the heart rate. So this is alert you that there is sepsis. Severe sepsis is sepsis with evidence of organ dysfunction. So, for example, there is increase in the liver function test or high urea and creatinine. So there is organ dysfunction or high lactate. This also, by the definition, is a severe sepsis. and of course, septic shock when there is decreased cardiac output and hypotension. So it's very important to recognize when the patient arrives to the hospital, what the nurses do, they will triage the patient. They're checking his vital signs, and if they think his heart rate is up, temperature is up, so they need to put alert to the doctor that this patient, he might have sepsis, and he might end up into septic shock if we not recognize it early and if we don't treat it. So next question, Dr. Mohammed.
Okay, تمام. You are treating an obtunded 72 سنة old female for severe sepsis due to pneumonia. You have administered 3 liter normal saline and broad spectrum antibiotic. After performing endotracheal intubation, the patient BP getting down 88 على 34. CVB is 11 millimercury, and venous oxygen saturation 60, والlab values not yet available. والسؤال هو طبعا what is the most appropriate next step? تمام. اوكي تقريبا تمام. غالبيتهم جاوبوا انه هو begin infusion of norepinephrine 5 millimercury for 5 microgram per minute IV.
Okay, yeah, and this is actually the correct answer. Why? Because what will happen this in this patient? Clearly, he had a septic shock. Okay, so initially we give him 3 liters of normal saline and broad spectrum antibiotic, intubated. Blood pressure is still low despite having 3 liters of normal saline, and the CVB is normal. So the fluid what we are giving him is absolutely fine. So what's the next step is actually you need to give him a vasopressor in the form of noradrenaline, because noradrenaline it acts on the alpha-1 receptor and causes vasoconstriction. Because the problem here in the septic shock is the vasodilatation. So you need to constrict the blood vessels by giving noradrenaline. Okay, next slide. Okay, so if you suspect that the patient had a septic shock, it's very important, as we mentioned, to try to manage those patients as early as possible. Otherwise, as we said, the mortality is very high. So you need to insert IV cannula. You need to take blood for CBC, CRB, lactate is quite important, blood gases, and blood culture. Because blood culture very important before you give the antibiotic, but don't delay giving the antibiotic because of the getting the blood culture. if you think that there will be delay in doing the blood culture, don't delay giving the broad spectrum antibiotic. Culture also, you need to take it from the suspected source, like sputum, urine. If a patient had intravascular catheter, you can do culture for that as well as from the wounds. Should also be taken for culture. Ideally, you should take 2 sets of blood culture, aerobic and anaerobic, for 4 hours apart. But usually in clinical practice, we're just taking one set of blood culture. So it's very important to treat those patients, giving them fluid, okay, 30 ml per kilogram per hour. And you should do that within 3 hours of patient presentation. Antibiotic, it should be given within 1 hour. We call it the golden hour. It should be done after the blood culture. But as I said, if you think that there will be delay in giving antibiotic, don't delay it because of the taking blood culture. Identify and control the source of infection. Of course, this is quite important. So if there is an abscess, you have to drain it. If there is infection inside, the chest or the abdomen, it has to be removed. Otherwise, the antibiotic has no effect. Vasopressor, as we mentioned, if a patient, you are giving him fluid and he's not responding to that, and the CVB is normal, you should think about vasopressor by giving noradrenaline, because noradrenaline is the main treatment for septic shock, because it causes vasoconstriction. Okay, so what do we call it? We call it, there's the sepsis six bundles. You take 3 and you give 3. So you take blood for labs, including blood culture, and you need to do also strict intake and output charting. Check the urine output, and you give 3. You give oxygen, you give IV fluid, and you give antibiotic. If you think the patient is the antibiotic, actually it's a broad, as we mentioned, broad spectrum. Depends upon the likely pathogen. So it should act against gram-negative and gram-positive. If you think the patient had an MRCA, you should give vancomycin. Monitoring is very important. So you need to check the mean arterial pressure. You need to keep it equal or more than 65. And you need to check the lactate level, because lactate is quite important. If it is high initially and you resuscitate the patient, you need to check it again. If it is coming down, it means that you're not doing the right thing. So it has effect in the responding of the patient responding to the treatment by measuring serial lactate level. Okay, another question, Dr. Mohamed. Dr. Mohamed?
Okay. With regards to anaphylactic shock, what is the correct answer? Okay. الغالبية طبعا مشوا ل for refractory cases epinephrine infusion 0.5 can be initiated. بعدهم undiluted epinephrine 0.5 milligram should be given IV antibiotic.
الماجوريتي اللي هم اللاست answer اللي هو for
last one بالضبط.
ايه. Okay, and this is actually the correct answer. Okay. So I can remove this.
تمشي اللي قبلها.
لا البول بنحول اوكي.
Okay.
So anaphylactic shock. خلينا نحاول نرد السؤال معلش مرة ثانية. السلايد بتاعي. نرجع للسؤال ممكن ولا مش ممكن؟ Okay. So anaphylactic shock is one of the shock that caused by maldistribution, okay, because of the vasodilatation. Because what will happen, there will be allergic reaction of the antigen, and this will cause increase of the histamine and activation of IgE and mast cells, cytokines, and it will act on the H1 receptor and H2 receptor. So the H1 receptor causes vasodilatation, increased capillary permeability, and causes hypotension, and also it will cause bronchial smooth muscles contraction. So the patient, he will be in respiratory distress. Of course, there might be, urticaria rashes. Not all patients with anaphylactic shock, they will present with urticaria. I think 20% of them, there is no skin lesion. There might be, swelling of the lips, swelling of the tongue, patient feeling, tightness in his neck because of the edema. And the activation of H2 receptor, what will cause increased gastric acid production, and the patient, might have vomiting. So the next slide. دكتور محمد.
جرب من عندك ها.
ايوه. So what are the signs and the symptoms of the patient presented with the anaphylactic shock? So in the airway, there will be, swelling of the upper airways, the lips, tongues, throat. There might be hoarseness, stridor because of the partial airway obstruction. Breathing, respiratory rate will be high. Patient will be with low oxygen saturation. Sorry, circulation patient will have, pale, clammy, and tachycardic, and low blood pressure. So the management actually is ABC. It's very important to control the airway. So if the patient presented with severe anaphylactic reaction and he's hypotensive, and you find that his lips is swollen, tongue is swollen, you need to think about securing the airway, because if you don't secure the airway, what will happen? It will happen later on. There will be an increased edema, and there will be complete obstruction of the airway, and you cannot intubate the patient after that. You might end up doing cricothyroidotomy. So it's very important to make sure the airway is patent, and if you think there might be an obstruction, you have to think about intubating those patients as early as possible. High flow oxygen, IV fluid. The main treatment is adrenaline. Okay, adrenaline 1 to 1,000. You need to give 0.5 milligram IM, not IV, and you can repeat the dose every 3 or 5 minutes. So you can give the initial dose, check the response. The patient not responding, you can give him more, adrenaline. But this is the main treatment for anaphylactic shock. If you don't give adrenaline and you give, rely only on antihistamine and the hydrocortisone, the patient will not survive. So you need to give them adrenaline, and if they are refractory, you can give them IV as well. IV small doses of infusion, as the MCQ stated in the last one. Of course, you need to identify and stop the causative agent. And more important, if the patient presented and you diagnose him with anaphylaxis, you need to tell the patient that he's allergic to certain drugs, especially if the patient in the hospital and you start to give him antibiotic, and you find that the patient is allergic to that antibiotic. You need to stop that antibiotic, and you need to tell the patient and put it on his file. So when he comes next time to the hospital, they will know that this patient is allergic to this drug, so they will not give him that drug again. Patients who have repeated attack of allergies and they are high risk, usually they will give him adrenaline, like we call it EpiPen, in the form of or the dose of 0.3 milligram. So they can inject themselves if they are outside the hospital, and if they exposed to allergen and they in a state of shock, they can inject themselves with adrenaline IM, or or their relative. They can do that. Okay, the neurogenic shock is the last one, which causes distributive shock, and this is caused by injury to the cervical or high thoracic sympathetic trunk. So there will be no sympathetic activity, and there will be increase in the parasympathetic activity. So what will happen if there is decreased sympathetic activity to the heart? There will be decreased cardiac output, so the patient will be hypotensive and bradycardic. The skin will be warm and dry skin. It's very important to recognize it, especially if the patient had an injury to the spine. But it's very important to rule out other causes of shock, okay? Especially hypovolemic shock. So if the patient is still in a state of shock and they are hypotensive and bradycardic, you have to think about neurogenic shock, because this is the only shock time you have to think about neurogenic shock. Neurogenic shock is different from spinal shock. Okay, so spinal shock is actually a contusion of the spine. and it causes flaccidity and loss of muscular tone, loss of reflexes, and duration varies, but it is completely different from neurogenic shock. How we manage neurogenic shock? Of course, A, B, C, D. So if you think there is an injury to the cervical spine, you need to put the patient in cervical collar from the beginning. You need to give fluid, but you have to be careful with the fluid, okay? Because those patients, they are not hypovolemia, they are, and you might end up causing, pulmonary edema. Patient, if not responding, you need to think about giving them vasopressor and inotropes. Of course, you need to avoid hypothermia, especially in elderly and in children. Okay, and I think this is the end of my talk. Thank you for listening. And if there is any questions. دكتور محمد.
شكرا دكتور، بارك الله فيك على هذا البرزنتيشن وهذا إذا في أي أسئلة طبعا نقدر نكتبه في الQ&A. دكتور أحمد لودي، تفضل دكتور أحمد.
السلام عليكم.
وعليكم السلام.
تسمع في واضح تو يا محمد؟
مقطع الصوت.
لو تسمع فيها محمد صاروا برزنتيشن الحق وشاملة، بس هي شوية ملاحظات حنحاول إن معلش لو اتسع صدركم وإن شاء الله ما توليش محاضرة ثانية، نحاول إني نقولها في الحاجات اللي أنا لاحظتها إن زي ما تقول أخطاء نمارسوا فيها في المانجمنت أوف شوك أو حاجات نغفلوا عنها يعني إحنا في بلادنا. من أهم الحاجات اللي هي في الديفرنشيال شوك في الدي دي ليست متاعنا أو ديفرنشيال، استخدام البوينت اوف كير الترا ساوند مهم جدا في how to differentiate types of shock especially الموست كومن اللي هي السبتك شوك ولا كارديوجينيك شوك. استخدام حاجه اسمها رش بروتوكول اللي هو رابد اسسمنت سونوغرافيك اسسمنت اوف and differentiated shock، انك انت تستخدم البروب بسرعه في 3 دقائق، تحط على الهارت وتشوف الكونتراكتيليتي وتعرف اذا كان هي الكارديوجينيك شوك سببها MI، في نفس الوقت تشخص في نفس اللحظه اذا كان في تمبوناد او بيريكارديال فيوجن. تنتقل بعدين اللي هي احنا نقسموا فيها نقولوا البايب والبامب والتانك. البامب اللي هي الهارت، البايب اللي هي الاي في سي، وتشوف الريسبيراتوري كومبرسبيليتي نتاع الاي في سي، وتشوف المخزون اللي عندك في الهايبو، هذه في دايجنوز نتاع الهايبوفوليميك شوك، وايضا باش تعرف انه هو فلويد ريسبونسيف ولا لا. بعدين تجي للبايب اللي هي الاورطه والدي في تي اذا كان في دايسكشن والله انيوريزم. فبالشكل هذا انت في خلال دقيقتين او 3 دقائق بالالترا ساوند درت الديفرنشال. فهذا حاجه مهمه، نحن نستخدم البوينت اوف كير الترا ساوند زي ما انت ذكرت حضرتك مبكري في حاله التنشن هيموثوركس، في حالات التروما والدوشه نتاع التروما من اللي يقدر يسمع البريث ساوند كيرفولي والله يدير البركاشن، والله لازم نعتمدوا عليه الالترا ساوند في الفاست سكان. طبعا وما نغفلوش عن الموريسون باوش اللي هي الفلويد. هذه حاجه. الحاجه الثانيه اللي هي انت ذكرتها بكري ومهمه، نحن ما نعتمدوش عليه السيستوليك بلاد بريشر. السيستوليك بلاد بريشر زي ما شفت في كلاس 3 لما نقص عندك السيستوليك بلاد بريشر انت ماشي للاند اورجان فيلير. فاهم شيء اللي يعتمدوا عليها الام اي بي. الام اي بي اللي هي 2 ضرب بالسيستوليك زائد الدايستوليك على 3. احنا ديما نقولوا في مثال لو ان عندك بيشنت ضغطه 110 على 40 وبيشنت ضغطه 90 على 60، من هو اللي عنده برفيوجن الاورجن برفيوجن احسن؟ اكيد اللي ضغطه 90 على 60 لو تحسبها يطلع الام اي بي نتاعها 70، بينما اللي ضغطه 110 على 40 الام اي بي بتاع 63. فركزوا على الام اي بي لان الانسان زي ما يقول احد اساتذتنا يقضي ثلثين حياته في الدايستوليك، فالدايستوليك عندك اهم. في حاجه ثانيه بالاضافه للام اي بي، يعني اول ما يجيك البيشنت تسجل الام اي بي تقيسه وتسجله، ويكون التارجت نتاعك انك انت توصل للام اي بي مور ذان 65 طبعا في المانجمنت نتاعك زي ما ذكرت حضرتك. الحاجه الثانيه مهمه نغفلوا عليها الشوك اندكس. شوك اندكس اللي هو الهارت ريت على السيستوليك بلاد بريشر، مهمه جدا لان هي اصلا تعادل السيرس كرايتيريا. لما انت تلقى الشوك اندكس هو الطبيعي المفروض يكون اقل من 0.7، تقسم الهارت ريت على السيستوليك بلاد بريشر، لو اقل من 0.7 هذا نورمال، اكثر من 0.7 معناتها انت لازم يعني انت عندك سيرس كرايتيريا اوريدي، لازم تبدا بالفلويد مانجمنت نتاعك حسب البروتوكول والايرلي انتيبيوتيك وكل شيء، ويكون هدفك انك انت خصوصا اهميتها لما انك انت من 8 هاي لايكليهود تو يصير لك بوست انتوبيشن ارست. فحاول ان كل مريض عندك لما تلقى الشوك اندكس بتاع 8 حاول انك انت تبدا في الفازوبريسر، تبدا في النور ادرينالين بتاعك ولا تبدا في الفازوبريسر قبل ما تدير له انتوبيشن. اذا هذا الشوك اندكس. قلنا على ام اي بي الشوك اندكس، استخدام الالتراساوند. الحاجه المهمه واللي بنقولها هي ايرلي فازوبريسر. لازم تبدو اول ما تعطي الفلويد، مرات حتى ما تستناش الريسبونس او الريسبونس نتاعك ماكش راضي عنه. كيف نستخدم الريسبونس؟ قلنا نستخدم الالتراساوند بالاضافه الى باسيف ليج بريس تيست. ترفع الرجل وتستخدم الالتراساوند على الاي في سي تشوف الكولابسيبيليتي، او تستخدم الاورتيك بالسيشن. طريقتين يعني في دقيقه تعرف منها هل البيشنت هذا ريسبونسيف، تمشي تزيد الفلويد ولا لا، او تحط البروب على اللنجز وتلقى بيشنت عنده بي لاينز، معناتها البيشنت اوريدي في كارديوجينيك شوك، اي فلويد بتزيده حيضر المريض مش حيفيده. او بيشنت عنده ار في ديسفانكشن اللي هم عنده ماسيف بالمونري امبوليزم، لما تدير الايكو وتلقاه البيشنت عنده رايت فنتريكولار دايليتيشن، هذا ما تزيداش فلويد، ادى بالايرلي فازوبريسر. حاجه مهمه نقطه حتى يلا حطها عندنا في مستشفياتنا، يخافوا من الفازوبريسر ما يبدوش في البريفرال، يستنى لين يركب سنترال لاين، لا، تقدر تبدا النور اد بسرعه في البريفرال لاين وبعدين ليتر في الاي سي يو يو كان شيفت تو سنترال لاين. اذا تبدو ايرلي انتيبيوتيك. راهو لما تكون ايرلي فازوبريسر، راهو في دراسه تقريبا باي ات اول او حاجه زي كذا مشهوره، لقوا ان 5% مورتاليتي على كل ساعه تتاخر في الفازوبريسر. اذا ما تتاخروش في النور اد، ابدا بالفلويد وابدا بالنور اد بسرعه في حالات السبتيك شوك. الفلويد راهو في توجه الان في علاج الشوك وفي التروما ان احنا نعطوا شويه فلويد، ان احنا يكون المانجمنت نتاع فلويد كونزرفتيف. في التروما في حاجه اسمها اللي ذكرتها يا دكتور بيرميسيف هايبوتنشن، الدامج كنترول ريساسيتيشن. الدامج كنترول ريساسيتيشن اللي هي انك انت اول ما تبدا الليترا فكر في الايرلي بلاد والايرلي بلاد برودكتس، يعني ما عادش اللي هي 1 to 1 نسبه، ما عادش في حاجه اسمها نعطوا فيزاز لتر 3 لتر زي زمان، اللي الزمان تغيرت. الفلويد سواء كان شوك للكوزز الميديكال او في تروما، لانك انت لما تعطي فلويد يصير دايليوشنال كواجلوباثي، وهذه واحده من الحاجات القاتله، يصير ديسربشن للكلوت. اذا الفلويد مانجمنت لازم تكون بكيرفول وما يكونش اوفر زيلوس. وزي ما قلنا ناكد مره ثانيه على اهميه ان نتعلموا حاجات بسيطه. الالتراساوند تندار في اللي ذكرناها كلها تندار من دقيقتين الى 3 دقائق. واسف على الاطاله، وشكرا لك يا دكتور، شكرا دكتور محمد، شكرا للجميع.
شكرا، بارك الله فيك. لا، هي ملاحظات الحقيقه في محلها، بارك الله فيك. agree totally يعني what you mentioned. yeah nice. thank you.
شكرا دكتور أحمد لدي. ناخذ بعض الأسئلة. how to differentiate between types especially in elderly presented to emergency between تقريبا types of shock، هذا ما يقصد. دكتور محمد مازن.
أيوة.
سؤال how to differentiate between types of shock especially in elderly presented to the emergency department.
We mentioned this. I mean, how to differentiate. We mentioned it already. يعني between مثلا الهايبوفوليميك والكارديوجينيك شوك يعني depends على الهيستوري الاكزامينيشن الانفستيجيشن. So you can differentiate يعني ما بين مثلا الهايبوفوليميك شوك كارديوجينيك شوك سيبتيك شوك. We did mention that in the presentation.
اوكي. كيو سوفا فايس سيرس قال لك هي من اللي مثلا نستخدموها اكثر الكيو سوفا. الكيو سوفا طبعا اللي هي الكويك تقريبا sequential
هي
organ failure assessment. اوكي.
الكيو سوفا اللي هي الكويك سيكونشال اورجان فيلر اسسمنت هي عباره عن الريسبيراتوري ريت يعني الريسبيراتوري ريت I think more than 22 والسيستوليك بلاد بريشر less than 100 والترد mental status. هي ما فيهاش there is no proved study about using the QSOFA في الشوك، لكن هي mainly measuring the high mortality بالنسبة للQSOFA mainly for the high mortality. So if there is more than two of those three, the mortality will be high. اللي ذكرت من respiratory rate والsystolic blood pressure والaltered mental status.
اوكي. معلش دكتور، شنو الفرق بين النور ابنفرين وبين الدوبيوتامين في المانجمنت؟ هو للامانه
النور
اوكي go ahead.
النور adrenaline act mainly on the alpha receptor. Okay, so it will cause mainly vasoconstriction. That's why it is important to use it in the septic shock, because in septic shock the main cause of the hypotension is vasodilatation. So noradrenaline act mainly on the alpha receptors. Dobutamine act mainly on the beta-1 receptor. So act mainly on the heart, increasing the heart rate and increase the contractility. So the dobutamine mainly used for the cardiogenic shock, but noradrenaline mainly used for septic shock.
تقريبا هذا كل الأسئلة. Q&A. What's the role of fluid in neurogenic shock?
In neurogenic shock, you have to be careful giving the IV fluid because of the hypotension and bradycardia, because it decreases sympathetic activity, so there is vasodilatation. You can give fluid, but you have to be careful with it, especially elderly patient or patient who had history of heart disease in the past. So you have to be, if you give too much fluid, patient might end up into cardiogenic shock and pulmonary edema. So you have to be very careful with that.
About tranexamic acid use in hemorrhagic shock, 1 gram over 10 minutes, then maintenance dose. What is the maintenance dose? Is I think
tranexamic acid, it has to be given within 3 hours from the injury. Okay, so you need to give 1 gram over 10 minutes, and then 1 gram over 8 hours infusion. But it has to be given within the first 3 hours from injury.
Main alarming signs of neurogenic shock and how to differentiate it from cardiac shock and polytrauma.
النيوروجينيك شوك هي انجري للسباين للسمباثيك اللي في السيرفايكال سباين والابر thoracic. This is where the sympathetic. So if you suspect an injury there and the patient is hypotensive, bradycardic, of course you need to rule out other causes of shock, but you have to think about neurogenic shock, especially if the patient is hypotensive and bradycardia. Cardiogenic shock, there is no trauma, especially to the spine. So that's the main the main difference.
اوكي تقريبا إذا كان البيشنت with renal failure, what is the best vasopressor or vasopressor?
With renal failure, what's the cause of his shock? Because it depends upon what kind of shock. But you can give dopamine, you can give all other vasopressor, but you have to give it in the lower dose.
اوكي تمام. تقريبا اوكي. مشكور جدا دكتور محمد، بارك الله فيك على وقتك، وجدا
شكرا.
نشكروك وعلى المحاضرة القيمة والمعلومات. أقل شيء درت برين ستورمينج وريفريشمنت للأمانة، ونتمنى نتلاقوا معك مرة قادمة إن شاء الله، يا إما بالويبينار يا إما إن شاء الله فيس تو فيس. حاجة واحدة قبل ننهي الويبينار، بعد إذنكم طبعا just إنه إذا كان I will stop